number one thing has to be we can't have it affect the United States. We can't have Ebola cases coming here.
2 American passengers exposed to Hantavirus on this cruise ship blocked from leaving this Nebraska hospital.
Right now, public health officials are watching 2 very different outbreaks. Ebola, a terrifying disease with a mortality rate that can be almost hard to comprehend, and Hantavirus, which also has a terrifying mortality rate, but which most Americans know, if they know it at all, as the thing you worry about when you discover mouse droppings in the attic. To be clear, neither outbreak has reached anything remotely like COVID's scale, but they do stir up some COVID-era fears. And they raise an uncomfortable question. If another serious pandemic threat emerged tomorrow, would we be ready? We should be readier than ever because we have extraordinary tools that we didn't have a generation ago. mRNA technology, faster sequencing, better global scientific networks, and surveillance, and better ways to share information. But we also have some glaring weaknesses. We have fragile public health institutions, testing systems that have failed before, and gaps in global surveillance. And maybe most importantly, we have a trust gap. A lot of people still have deep distrust left over from the last pandemic. So today, I'm joined by my colleague, Dr. Leana S. She's an emergency physician and also a Washington Post contributing columnist who's focused on public health and health policy. Probably like many of you, I have a lot of questions about what's going on with Ebola and Hantavirus and about whether we're better prepared for a bigger outbreak or just more exhausted and angrier than we were the last time. Leana, welcome to the show.
Thank you, Megan. Great to join you.
Let's actually just talk about where we are on pandemic preparedness, because I think this goes into it a little bit, right? I worry often that the pandemic left us unprepared for another pandemic. On the one hand, we have not fixed, as far as I know, a lot of the problems that we didn't get right the first time. Not only did we not do a lot of that stuff, we've had so much reaction, so much anger and distrust that I think we're in a lot of ways in a worse position. I mean, I made an offhand remark on Twitter where people were like, I'll never lock down again. And I was like, look, I don't think Hantavirus is going to go pandemic, but if Hantavirus goes pandemic, you are definitely locking down because it's got a 40% mortality rate and you are not going to be sending your kids out to play baseball in the hopes that one of them will come home, right? And people freaked out as if I was ready to lock down America for Hantavirus immediately. I was like, guys, you can have an intellectual conversation without everything turning into a fight about 2020. But I think most of the public doesn't feel that way.
Right. I mean, to your point about what have we improved or what have we not, I think we can point to a few things. I definitely think that the mRNA technology that allows us to deploy vaccines much more quickly than traditional platforms is a godsend. I think it's terrific. I think we should be using this a lot more. But we also know that somehow the phrase mRNA has become so controversial, even though it doesn't merit that kind of controversy scientifically, that that may not happen with this current administration. I think to your point, why are we not building more capacity for testing? The question is testing against what, right? I think that Hantavirus is a really good example of this. Ebola has every few years or so, it's popped up and has been an issue. So one could say we should be prepared for Ebola, but Hantavirus is rare. And this was really unexpected. And like you, I don't think that this is going to be the great pandemic for a number of reasons, including that it is uncommon for it to spread person to person. Although certain cases have happened in the past, certain events have happened in the past where it looked like it was spread beyond just close prolonged contact. Generally, it requires close prolonged contact. So it's not the kind of virus that we worry about.
Fun story. Maybe it's a fun story. A few months ago, I went up to my dad's house. He died in 2024. And we're clearing it out. And there was a mouse infestation. So I had to fly to Boston and spend a weekend dealing with a mouse infestation. It was really horrible. And unfortunately, I cleaned up all the mouse droppings and then made the mistake of going to the CDC page on how you should deal with mouse droppings.
Yes, I totally agree. For example, and I think these are things that people just may not know about. For example, the importance of wearing a mask, right, is something that you just don't know about, or how you really don't want to aerosolize dry droppings, that you should put water on it and then clean up. I mean, these are just things that maybe you wouldn't know if you were not on the lookout for hantavirus.
But the other thing that I learned in the course of my studies is that there's more than one hantavirus. And I think this has been confusing a lot of people because the hantavirus in the United States, mostly in the Southwest, only spreads from mouse droppings. It does not spread person to person, or it never has. I guess it's not impossible that it ever could. But there is one strain of hantavirus, which is in South America, that does have person-to-person transmission. It's not that common, but it does happen. And so I think a lot of people thought, no, I already looked, hantavirus doesn't spread person to person. And that's the CDC advice because that's the only kind we have in the United States. But there's more than one. And this particular strain that was on the cruise ship is known to spread person to person. This is not some big mutation event. It actually looks pretty similar to earlier outbreaks of hantavirus, is my understanding.
That's exactly right. So the strain that's predominant in the U.S. is the Sin Nombre strain. And this strain, again, of the almost 1,000 cases that we've had here in the U.S., none have been person to person. They have all involved mouse droppings, mouse urine that somebody accidentally aerosolized. In rare cases, it could also be from an infected mouse bite, but it's not person to person. The Andes strain, which is found in Argentina, in South America, and other places, again, can be spread person to person. Not commonly, but can be spread person to person. And there was a 2018 case that appeared to be a type of super spreader event where individuals seem to have infected others even without close prolonged contact, which normally we think about close prolonged contact as you live with somebody, you share a bed with somebody, etc. But even without that kind of close prolonged contact at parties, at events, people did seem to contract hantavirus that way. That said, that is still an outlier case. And so here we're talking about a rare person-to-person and then rare except through prolonged close contact. We don't have a lot of information yet about what happened on that cruise and whether the infected people were all close contacts, maybe they all had dinner together, or maybe they just had passing interactions. We don't know that yet. But I do think that the specific situation of everybody being on a cruise together over the course of multiple days increased that level of risk. And I think it's just one more reminder, though, to your point earlier of how we could have new viruses that come up, as in the case of COVID, right, of the coronavirus. It was a novel coronavirus. But we could also have old viruses. Hantavirus, we've known about it for decades. We could also have old viruses become a problem in specific situations, too.
And Ebola is a somewhat old virus. I believe it was discovered in the 1970s, but we've had these recurrent pandemics. Now, there is a belief online, it seems logical to me, but many things that seem logical to me turn out not to be true, that things that are really, really fatal have a hard time spreading, simply because it's very hard for people to, like, you basically, you get so sick that you're not moving around and spreading it. Is that right? Is there a direct trade-off, or is it more complicated than that?
No, it is true. It is true that if, let's say that a virus or a disease infects somebody and immediately they become very, very ill to the point that they're not going to parties, they're not going to events, they're not going to restaurants, and the key is if they're also only infectious during their symptomatic period, then it's less likely for the disease to spread. They might still spread it to their caregivers, to healthcare workers, to people around them, but they're unlikely to go to big events and spread it in the case that we've seen, for example, with COVID or measles or others, where you may be mildly symptomatic or not symptomatic and still be able to spread it to other people. So that, I suppose, is the quote unquote good thing about Ebola, right? That people do tend to become very ill pretty quickly, and they're unlikely to be going to events when they are so sick and unlikely to spread it to others. But let me give you some nuances and some specific challenges with Ebola. The first is that the initial symptoms are really nonspecific. We're talking here about fever, muscle aches, fatigue, things, especially in sub-Saharan Africa, where there is malaria, there's typhoid fever, and just the flu and other respiratory illnesses. Early Ebola could look like anything. And this is one reason why healthcare workers are typically the first to become ill and to die from Ebola, because they're treating patients. They think that the patient has something else. Ebola was not on their list of possibilities at all. The American doctor who has Ebola is believed to have been treating a patient who had abdominal pain. And he thought that maybe it was a gallbladder problem, but operated on the patient and then realized that it was actually Ebola. Also, early Ebola could look like labor, and Ebola could be especially damaging to pregnant women. And so patients come in looking like they're in labor, and doctors are treating them thinking that they're in labor, and maybe they are in labor, but actually this patient also has Ebola. And so lots of OBs and clinicians working in the OB setting have died as a result of this. And so yes, it is true that later Ebola, and the progression is rapid, but later Ebola looks horrific. And patients are not going out and about during that period when they're bleeding from their orifices and they have multi-organ failure, but patients can still be transmitting the virus early on. The other issue with Ebola that is quite specific to this disease too is that it's transmitted through objects, through contaminated objects, including sheets and utensils and clothing. And even after somebody has died, the objects that they contaminated in their bodies can still carry the virus. And so quite a number of cases of Ebola in the past have been transmitted during funerals. And obviously to caregivers, but also to people coming and participating in traditional burial practices, when maybe they're touching the body or they're touching objects that the infected person may have had. And so I think all those factors make Ebola hard to contain. And I am really worried about this outbreak. About 20 years ago or so, I worked in the Congo and in Rwanda, and the healthcare infrastructure there is very limited. In Eastern Congo, we're talking about towns that already lack healthcare providers, that are very resource poor, and I think that the case count probably is much, much higher than we know of, that the outbreak probably spread weeks, if not months earlier than was reported. A lot of people may have just died at home, and then their relatives got infected. These are also conflict-ridden zones where there's going to be difficulty getting aid, in part because it may be difficult to ensure that the aid workers are going to be safe. So I'm really worried about where this outbreak goes, and I think what the U.S. can do more than anything else is to provide the resources to these countries that are desperately in need of them.
It's almost summertime, friends, and you know what that means. It's time to fold up the cashmere and the wool, put them away under the bed or on a top shelf so you have more room in your drawers for your linen and your crisp, cool cottons. It's also time to update that summer wardrobe. That's why I've been spending some time on the Quince website, planning my attack on summer fashion. I'm trying to be more intentional about what I wear day to day, leaning into pieces that feel effortless, comfortable, and still put together. And Quince just makes that easy. It makes getting dressed simpler because you know it'll look good before you pull it out of the shipping envelope or the box. The fabrics feel elevated, the fits are flattering, and everything just works without overthinking it. My European linen top looks great with my Quince wide-legged jeans or my summer gauze pants. And my cotton cashmere sweaters work with my washable silk dress or my ponte knit work pants. I gotta be honest, I'm not just looking at clothes for myself. No, I'm not talking about my husband, although he has cast an eye on the Quince website too, but I'm talking about my bed, which is already wearing Quince's incredible European and linen sheets for the summer. I'm eyeing a second set just so I don't have to tear them off and rush them down to the laundry and get them right back on the bed, because after a summer of sleeping on those sheets, I cannot go back to anything else. They're so cool and luscious when the weather is hot. Luckily for me, Quince makes it easy to refresh your everyday with pieces that feel as good as they look, because they use premium materials like 100% European linen, organic cotton, ultra soft denim. Their lightweight linen pants, dresses, and tops start at $30 and are effortless, breathable, and easy to wear on repeat. In fact, everything at Quince is priced 50 to 80% less than similar brands because they work directly with ethical factories and cut out the middleman, so you're paying for quality and craftsmanship, not brand markup. So refresh your everyday with luxury you'll actually use. Head to quince.com/Megan for free shipping on your order and 365-day returns. That's now available in Canada too, by the way. That's QUINCE.com/MEGAN for free shipping and 365-day returns. Quince.com/Megan.
I think that one of the sort of sad truths of American politics is the only thing everyone agrees on cutting is foreign aid. All the voters, when you poll it, it's the only program people are like, yeah, definitely cut foreign aid, even though it's a teeny tiny portion of our budget. But I mean, it strikes me that the case for containing diseases like Ebola is pretty self-evident. We don't want this getting on a plane and coming to the United States. We don't want it going to Europe and then coming to the United States. We don't really, unless you are actually planning to turn us into Fortress America and never leave. Controlling infectious disease around the world is almost the most straightforward, just selfish case for foreign aid. What should we be doing for that? And am I right that there is ultimately a risk to America, even with a disease like Ebola that arguably is going to burn itself out because people die so quickly? I mean, it still is something of a risk to us, right? Just having this out in the world.
Yes, and we saw this in the 2014, 2016 Ebola outbreak when we had people returning to America, then infecting healthcare workers in the US. And so I completely agree with you that it is a matter, of course, there are ethical considerations and our responsibility to our global citizens, but also a very specific self-interest. Because even if you think about Americans who want to travel, I bet a lot of people are rethinking their travel to certain countries, including Uganda, where there are now cases from this outbreak because of it. And now we are already seeing travel restrictions being imposed on non-Americans who have been in countries that are affected or potentially affected, but at some point soon, we may also see restrictions on Americans. And here's the thing, it is much, much better for us to control the infection at the source rather than letting it spread so much that we have to apply travel restrictions and build that fortress, as you said, right? It's a lot better for us to control the outbreak, stop it from spreading further into other parts of Africa, into Europe, and then trying to prevent those travelers from coming here, preventing Americans from going. That's really not in anyone's best interest. And so in terms of what these countries need, I would say right now, they need workers because their healthcare workers are dying. Their healthcare workers are afraid. We need equipment. There isn't enough PPE, personal protective equipment, for the workers who are on the ground. Also, they need individuals who are there doing the work of contact tracing, of identifying who's ill, of going out to villages and providing education and support. So all of that requires intensive resources, and we could help in funding clinics, in providing that PPE, and providing the workers. But I would say this underscores the point about what is America's obligation in the first place. I think that in time to come, we're going to be able to draw a direct line from cutting USAID funding, cutting our support initially to countries like the Congo, and seeing outbreaks that are much larger than would have been present if that funding had been in place, because that funding is what would have provided for the infrastructure, for the clinics, for the hospitals, for the workers, for the PPE in the first place. And I think it is just late. I mean, I hope the US does the right thing now and provide the funding that's needed, but it's late. And I also think that it's a great shame, a great stain on our reputation to not be a part of the World Health Organization, which is leading this investigation, which is coordinating across all these different countries. That's the job of the World Health Organization. And the US is now not a part of it anymore.
So I want to ask about a related question, because I think this actually goes to the vaccine problem, right? One of the things that makes people, and to be clear, I am relentlessly pro-vaccine, love the things, would get more if I could. I think one of the things that does give people pause, right, is that you're injecting a healthy person. And I think that intuition, actually, you saw this during the pandemic where people were saying, let healthy people just take the vaccines, right? Like, let them do challenge trials, stick this vaccine in someone's arm and then deliberately expose them to COVID. Let's hurry this process up and get this thing tested so we can get it approved as quickly as possible. But bioethicists were like, whoa there, little ranger. We can't do that. That's unethical. It's a healthy person. So I'm just wondering if we could explore this moral quandary a little bit. When should we be willing to let healthy people experiment, test things on themselves, and when should we not?
I think, so several things I want to say here. One is, I don't understand the paradox. The same people, including Robert F. Kennedy Jr., who seem to be very skeptical about vaccines because they're injected into people's bodies, are also great proponents of peptides. And that I just don't understand, because if you're against injections in healthy people, then I could understand being against both, but not being against one that has a lot of evidence, that has decades and decades of evidence, and for both safety and effectiveness, but you're really a proponent for these other things that don't have evidence. That mentally, I don't get that, right? There's an incongruency that I'm just not understanding. And then the other component here is, I think in the case of vaccines, the reason to do that is very specific. The reason to do that is we know that there is that other disease out there that is really terrible. I mean, you mentioned the case of measles, for example, the fact that the chance of getting pneumonia and being hospitalized for pneumonia, if you have measles, it's 1 in 20, that there are severe long-term consequences, not just death, but also you could end up getting measles, recovering from it, and then years later, getting a terrible neurological, neurodegenerative syndrome that you then die from. I mean, there are, you're trying to prevent that horrible thing from happening. In the case of peptides, people are really using this mainly as an optimization. They're saying, I'm not recovering quickly enough after this hard workout. I'm a triathlete. I want to recover faster. I'm using it for this very specific purpose to make myself better, which is a very different proposition than avoiding significant illness. And so maybe that incongruency is something that I'm wrestling with too.
Yeah, I completely take the point. And I think part of the problem when you talk about RFK Jr., for example, is that we are bad at drawing fine distinctions, in part because they're hard to describe in the public debate. You have a 2-sentence soundbite and that's all you get. And when I look at people like RFK Jr., I spent a lot of time during the pandemic arguing with vaccine skeptics. And again, on the margin, when people would say, well, this vaccine, it's brand new, it's never been tested. I was like, well, the bats weren't testing COVID either. It's not like they did a lot of clinical trials and we've got good safety data on it. I don't understand why you want to take something that had clinical trials, at least some, and you would rather do the completely untested thing from the bats. But I think that goes back to, there were a lot of public health failures during the pandemic, right? And that did undercut a lot of trust in the public health authorities that we want people to rely on. But the problem is, I take all those criticisms. I think they're right? And yet you can say all that and say that all of those things happen, but that doesn't mean that literally every single thing they say is wrong, or that they're literally completely useless. And the inability to distinguish between those two thoughts, I think, has become really common in our politics, but also really common in the way we approach personal health.
Yeah, very interesting. And I agree with you, right? I've spent a lot of time also looking back at the different periods of COVID and the decisions that were made. And there were so many things that happened because this was a new virus and people didn't know. And I think there could have been more transparency about what we knew and what we didn't know, what was speculation versus what had solid evidence behind it. I think some of the dogmatic way, perhaps, that some of this guidance was communicated, and the fallback of, everything is about the science, as opposed to explaining the science can only guide us so far, but at the end of the day, it's still about our values and policy decisions that are made because of these values and the science guiding us to them. But it's not just the science that's somehow coming up with these policies. I think what's really interesting now is looking to see what the current administration, which is made up of people who are very skeptical, one could say, very critical of the way that COVID was handled during the Biden administration, how these same individuals are handling public health crises that are being handed to them now. So, for example, we're now seeing that in the case of Hantavirus, that there are mandatory quarantine orders being placed on individuals who just came off of the cruise in which 3 people died from Hantavirus. These are individuals who are now saying that they want to leave the facility in Nebraska, but that they aren't able to leave because of mandatory quarantine orders. And they are saying they feel lied to because they had initially gotten the signal that they could leave when they wanted to if they had a quarantine plan in place in their home. And now they're being told that they cannot. And so I think it's interesting to see how the critics who are now in a position of power themselves are navigating this line between how do we protect the public versus respecting individual rights, which is a very, very difficult line to walk.
One of the things that has been striking about this Ebola epidemic is the stunning surveillance failure here. And I'm not casting blame on anyone, but something definitely went wrong. This thing became so much more widespread than it normally does. We normally catch it. Like before that, at this point, every public health expert I'm seeing is saying, guys, this is a lot of cases. This is not like a limited outbreak. This has obviously been spreading in the community for quite a while. And part of that is that this is a different strain. And unfortunately, it's also a strain for which we don't have a vaccine.
But here's another reason why the outbreak has spread so much more by the time that people realized. It's because the field tests, the rapid tests that are being done to look for Ebola, they test for the Zaire variant, which is the one that was the cause of the 2014-2016 outbreak and is by far the cause of the vast majority of cases, right? But the field tests are not detecting apparently this strain. And I don't think that was known before. And so all of these individuals thought that, or the clinicians thought these initial people who were dying or who were ill did not have Ebola. And I think that contributed a lot. The lack of diagnosis, to your point about the importance of testing, the lack of diagnosis contributed in a major way to the outbreak being as large as it was by the time that it was reported. As it turns out, the confirmatory tests do work. So the PCR tests, the tests that you have to send to the laboratory do work for picking up this strain, but the field test did not. And I think that was a failure that was not detected earlier. Now, I think why do we not have a vaccine? Why do we not have treatments? It's because this is not a common strain. This has caused 2 outbreaks in the past that we're aware of, but I would imagine that now with it being as large as it is now, that people are going to be trying treatments. And I think in this case, in the case of Ebola, this is a case where the right to try makes sense, that you do want to throw the kitchen sink at these people who have a 50% mortality. I mean, the mortality rate for Ebola is it's unimaginable, right? That in the average mortality is 50%. In some outbreaks, the mortality has been as high as 90%. If I have that high of mortality, I just give me everything that you have.
I think that's absolutely right. And I also wonder, what sorts of arrangements we could set up to incentivize people to have more tests available. I mean, one of the big problems with developing a vaccine for Ebola or in general in developing things for developing countries is that it's very hard to make money on them, right? You've got to go through all the testing, you've got to do the development, but then the people, if it's only something that you see mostly in developing countries, malaria falls into this, yellow fever, there's a number of diseases, Ebola is one of them. It's just very hard to get that funding. And we do not have an administration right now that loves vaccines, sadly.
Right. I mean, I agree with you, of course, that I think developing more testing, vaccines, treatments in advance is the right thing to do. But I want to go back to the point about infrastructure, that at the end of the day, you still need the workers, right? You still need the facilities. You still need the individuals doing the outreach. You still need the nurses. You still need the doctors. And those are the components that we are at the most risk of losing right now, not just from disease, but also from people not having hope in their country and leaving for other countries, understandably, because they want better opportunities for themselves and their families. But if the US could do more to try to incentivize those individuals to stay in their home countries too, that is also going to be key to responding to outbreaks in the future. And that is another reason why I do think that direct line will be able to be drawn between us cutting funding for hospitals, for clinics, which will also go to paying for these workers. I think we'll be able to see a direct line from that to more infectious diseases that kill Americans.
And what are you optimistic about right now with pandemic preparedness, with infectious disease control? When you look out in the world, what makes you like, maybe other things are bad, but this thing, I smile. I'm happy that's going on.
When I look at the general trend of where we are with the anti-vaccine movement, with not wanting preparedness, right, and focusing on treatment, but very specific treatments that may or may not have evidence. I mean, of course, the whole picture worries me. But I will say that what gives me some hope is that there seems to be more attention to what is it that we can each do to have better health. And yes, we're not doing enough as a system on prevention, but I think there's a lot more awareness of personal prevention and personal wellness. and the emphasis on health span and not just lifespan, and how can we live better and not just longer. I think that those are points that people across the political spectrum and ideological spectrum, from mainstream, if you will, physicians and public health experts to RFK Jr. and MAHA followers, I think they can all agree on the idea that there's more that we can do on a personal level to promote better health, whether it's with nutrition or physical activity, sleep, and so forth. Now, the other things we may not agree on, including vaccines and pandemic preparedness and so forth, but at least there are some things that really should have been priorities all along when it comes to prevention that I think we are recognizing more and more are essential to our health.
Leana, thank you so much for being with us.
Thank you, Megan.